Hi everyone. So in this mind map session, we will be examining the major topics and concepts related to the physiology of the respiratory system. And we'll begin with the phases of pulmonary ventilation. So keep in mind that pulmonary ventilation simply means moving volumes of air to and from the lungs. And we have two phases. The first is inspiration, which is describing inhalation, and the second is expiration, which is describing exhalation. The muscles that are involved in this are involved in either quiet inspiration and quiet expiration or forced inspiration and forced expiration. Now, quiet inspiration and expiration are simply the breathing, the pulmonary ventilation cycles that occur when we're at rest. So those are just normal breathing ventilation rates that occur just to maintain normal adequate oxygen exchange between the blood and or between the lungs and the blood. Forced inspiration, forced expiration happens when we are undergoing some kind of vigorous activity in which we need to increase the amount and the volume of air that's reaching the lungs each minute. So let's examine quiet inspiration first. So quiet inspiration involves the contraction of two muscles, the dome-shaped diaphragm muscle and the external intercostal muscles, which are muscles that exist between most of the ribs in the rib cage. And when these muscles contract, they expand the volume of the thoracic cavity. And when the volume of the thoracic cavity expands, that creates a slightly lower pressure inside of the alveoli and inside of the thoracic cavity itself, and promotes airflow towards the alveoli of the lungs. And so that's how the increase in volume creates a pressure change that's going to help to draw air into the lungs towards the alveoli where gas exchange can take place between the air in the alveoli and the blood that's in the capillaries that are surrounding those alveoli. Now, quiet expiration, on the other hand, involves the relaxation of the diaphragm and those external intercostal muscles. So quiet expiration doesn't involve any muscle contraction at all. So we say that it's a passive process simply because it's involved in the relaxation of those two muscles that we just examined. And what that does is that decreases the volume inside of the thoracic cavity when those muscles relax. And when that happens, that creates a slightly higher pressure inside of the lungs than in the atmosphere, and helps to push or force air out of the alveoli and out of the lungs. Now, forced inspiration, on the other hand, will occur during exercise or some other type of vigorous activity where we need to exchange larger volumes of air between the atmosphere and the alveoli so that greater gas exchange can occur. Now, forced inspiration not only involves the contraction of the diaphragm and the external intercostal muscles, but it also recruits several other muscle groups, including a muscle that attaches from the neck to the top of the rib cage called the sternocleidomastoid muscle. It also involves the scalene muscles as well as the serratus anterior, which are all muscles that help to, when they contract, they help to elevate and lift the thoracic cage, and creating that expansion in volume that I mentioned moments ago. Now, forced expiration, on the other hand, does involve relaxation of the diaphragm and the external intercostal muscles, but it also involves contraction of other muscle groups that help to compress the thoracic cage and decrease that volume in order to force that air, in order to create that pressure change that forces the air out of the alveoli and out of the lungs themselves. And the contraction of those muscles include the internal intercostal muscles, which are small muscles that are between the ribs that help to, when they contract, help to pull the ribs downward. The oblique muscles, so that includes the external and internal oblique muscles that are located kind of at the sides of the abdomen, as well as the rectus abdominis muscle. And so all of those collectively, when they contract, they help to pull the ribs downward to create a decrease in the volume inside of that thoracic cavity. So the next part of the respiratory physiology lab list is the identification of volumes and capacities on a spirographic record. Now there's plenty of practice in Moodle, especially in the lab report questions that I have for you. So I just wanted to go through here just real briefly and define some of these terms that you would see on a typical spirographic record. And these are a lot of the terms that I cover in my lecture material on the spirographic record as well. So first we'll start with the inspiratory reserve volume, which is abbreviated IRV. This is a volume that usually is shown as a very kind of large uphill slope on the spirographic record. And this volume indicates the amount of air that's forcibly inhaled, or the volume of air that's forcibly inhaled beyond that normal resting tidal volume. So you can think of the tidal volume, which is next. Tidal volume is just the volume of air that's moved in and out of the lungs with just normal quiet breathing, just to maintain normal oxygen saturation rates in the blood at rest, right? So tidal volume, which is abbreviated TV, is described or defined as the volume of air that's moved during that normal quiet inhalation and exhalation cycle. So on average for both males and females, adult males, adult females, it's about 500 milliliters per breath. So that's a really good number to kind of keep in mind for typical tidal volumes. Next, we have expiratory reserve volume, which is essentially the opposite of inspiratory reserve volume. It's simply the amount that's forcibly exhaled beyond tidal volume. And so inspiratory reserve and expiratory reserve would typically be during those times when we're seeing forced inhalation and forced exhalation by recruiting additional muscles to help increase or decrease the volume of the thoracic cavity that we just spoke about moments ago. So next we have the residual volume. And the residual volume is a volume of air that remains in the lungs even after the most forceful of exhalations. So this is the amount of air that we can never really get out of the lungs. So even when we forcefully exhale, there is still a volume of air that remains in the lungs, in the alveoli, to keep them inflated. And because this is a volume that remains in the lungs after even the most forceful of exhalations, we can't directly measure it. And instead, we have to estimate it using equations, using formulas that take into account three variables: gender, age, and height. And so in Moodle, you see, specifically in the physiology side of things for the respiratory system, you'll see two equations, one's for males, one's for females. And in those equations, it takes into account age as well as height, because age determines the ability of the lungs to expand when we inhale, or in reverse, the ability of the lungs to be compressed when we exhale, as well as our height, because height determines thoracic cavity volume. So there are some practice equations in there if you're curious about calculating and determining your own residual volume. Just find the one that's appropriate for your gender. You plug in age in years and you plug in height in inches, and it will tell you a volume in liters. The vital capacity, which is our next item on the spirographic record, is actually the sum of three volumes. It's the sum of inspiratory reserve, expiratory reserve, and tidal volumes. And vital capacity is really just the amount of exchangeable air, because as you see, vital capacity takes into account everything except the residual volume, because the residual volume is the volume or the amount of air that's remaining in the lungs, in the alveoli, to keep them inflated. So vital capacity is really just kind of describing how much air the lungs are able to move with a single exhalation and inhalation cycle. And then finally, the total lung capacity is really the same as the vital capacity, but we're adding residual volume to it. So total lung capacity is the sum of all four of those volumes that we talked about: inspiratory reserve, tidal volume, expiratory reserve, and residual volume. And total lung capacity really estimates the total amount of air that the lungs can hold or contain after the most forceful of inhalations. So that brings us to kind of average values as well as the units for things like tidal volume for the average adult female and average adult male. And these are typical healthy values for adult males and adult females. usually around 500 milliliters or 500 milliliters per breath. Now, of course, because this is an average, we're going to see individuals who have tidal volumes that are significantly lower than this, and we're also going to see individuals that have tidal volumes that are significantly higher than this. And so the average is simply that. It doesn't mean anything if you're above or below the average. It's just that's how averages work in terms of just compiling all of the typical values for many adult males and many adult females and just seeing where that middle value, that average value lands. The next value or number that I want you to keep in mind is the total lung capacity for both adult females and adult males. For adult females, that's about 4,200 milliliters total lung capacity. So that means typical female can have about 4,200 milliliters of air in the lungs after a forceful inhalation. And for males, that number is a little bit higher. It's about 6,000 milliliters. Again, those are pretty typical average numbers for adult males and adult females. And so for those tidal volume and total lung capacities, keep those three numbers, those three values in mind. As well as the units are always going to be milliliters there, or if you wanted to indicate milliliters per breath, because these are really just measuring the values in one inhalation-exhalation cycle. We mentioned a moment ago the three variables that are used to estimate residual volume, because residual volume is the amount of air that remains in the lungs even after a forceful exhalation. So this is a value that's not easily measured, but instead we have to estimate it using equations that take into account these three variables: gender, age, and height. So I'm not asking you to commit the equations to memory, but I do want you to understand the variables that are going into estimating residual volume or calculating residual volume. Next, we get into a little bit more of the physiology side of things with Boyle's law. And Boyle's law is a really important law because it really helps us understand how the pressure changes that are occurring during inhalation and exhalation are leading to the flow of air to and from the alveoli during those pressure changes. And so Boyle's law states that pressure and volume are inversely proportional to one another. And so what I mean by that is that if we think about our inhalation cycle, for example, or the inhalation part of the respiratory cycle, when we inhale, our thoracic cavity and our lung volume is increasing. And Boyle's law states that if the volume increases, the pressure inside of the lungs, inside of the alveoli, is going to decrease, at least compared to the atmospheric pressure. And so that's what we mean by inversely proportional. If one of those items increases, the other will decrease. So by creating an increase in volume, we create a decrease in pressure. And it's when we create decreases in pressure, that's where flow occurs. So the change in pressure kind of helps to determine where airflow is going to occur, or what direction airflow is going to occur, because air is always going to flow from high to low pressure. And so if we create a low pressure inside of the lungs and inside of the alveoli during that increase in volume with the inhalation, that decrease in pressure is going to create airflow into the lungs and into the alveoli where gas exchange is going to take place. Now, on the other hand, when we exhale and the volume of the thoracic cavity and the volume of the lungs decreases, that means that the pressure, according to Boyle's law, the pressure will increase. And we know that airflow will occur from high to low pressure. So if pressure inside of the lungs, pressure inside of the alveoli is temporarily raised during that exhalation cycle, that's going to create a force that's going to drive air out of the alveoli and out of the lungs. There's a video link that I put up on Moodle that demonstrates this with balloons in a bell jar. So there's a plastic bell jar with a rubber diaphragm at the bottom of it and two balloons that are kind of simulating the alveoli or simulating the lungs inside of the bell jar. And the balloons are connected to the atmosphere through a little stopper that has essentially a trachea in it. and it allows air to flow from the atmosphere to the balloons or from the balloons to the atmosphere, depending on what the pressure is like inside of the bell jar. So in that video, what you'll see is that when the rubber diaphragm on the balloon model is pulled down, just like when the diaphragm muscle in our thoracic cavity flattens out as it contracts, that's going to increase the volume inside that bell jar. And when the volume increases, the pressure inside that bell jar decreases, promoting flow from the atmosphere into the balloons to fill them up. The opposite will occur when the diaphragm is pushed up. We're decreasing the volume and increasing the pressure inside of that bell jar, and that's going to create a pressure that's going to squeeze air out of the alveoli or out of those little balloon models inside of the bell jar and force that air out into the atmosphere. So that's going to stimulate a normal exhalation. So that's why Boyle's law is so important for us, because it helps us to understand the changes in volume in the thoracic cavity during the normal respiratory cycle, and how those changes in volume relate to air flow into and out of the alveoli and into and out of the lungs. Another factor or variable that's really quite important in determining airflow is called resistance. And this was a variable that we saw with blood pressure, because we saw that blood flows from high to low pressure against resistance. So the lower the resistance, the better blood flow we're going to get. And it's the same way for air. So air behaves in a lot of the same way that blood does. It's just not as thick, it's not as viscous, but it still behaves in roughly the same way, in that if we create a lot of resistance to airflow, then that means that air is not going to flow as well towards where we want it to go. But on the other hand, if we decrease airway resistance, we're going to create better flow towards where we want that air to go. So the variable that is the biggest factor in changing airway resistance is airway diameter. So just like we saw that the biggest factor in changing blood resistance to blood flow is blood vessel diameter, right? And this all comes back to that French physiologist by the name of Poiseuille and Poiseuille's law. So we saw that Poiseuille's law, it determined resistance by using a couple of variables, and one of those variables was the radius or the diameter of the vessel that blood or that air is flowing through. And we saw that airway radius or airway diameter was in the denominator of Poiseuille's law, and it was also to the fourth power. So that means that if we increase that number, so anytime you make a number like radius or diameter bigger, and that airway radius or diameter is in the denominator of an equation like that, anytime that number gets bigger, that means that the resistance is going to get smaller, because anytime you divide a number by a really big number, right, in the denominator, that means that the number, the variable like resistance is going to go down because of that. But on the other hand, a decrease in airway diameter will correspond to an increase in the resistance to that airflow, because anytime that radius or that diameter number gets smaller and it's in the denominator of an equation like that, then that means that the resistance is going to get higher compared to when that diameter or that radius is smaller. One of the last of the physiology laws that we'll examine is referred to as Dalton's law. And Dalton's law is an important law because it helps us to understand what regardless of what's going on inside of the lungs, inside of the thoracic cavity, how easy is it going to be for oxygen to diffuse from the air in the alveoli into the bloodstream? So regardless of how that oxygen got into the alveoli, there has to be a pressure behind it, forcing it or pushing it to diffuse from the air in the alveoli into the bloodstream. And that's really why Dalton's law is so important, because it helps to highlight the fact that the pressure behind that oxygen is really, really important in getting it to diffuse into the lungs. And so, or into the bloodstream of the capillaries that surround the alveoli. So Dalton's law maybe kind of confusingly states or is described as the total pressure of a mixture of gases is equal to the sum of the partial pressures of each gas that's in that mixture. So if we think about Earth's atmosphere for a moment, Earth's atmosphere is a mixture of gases, and the two main gases that make up Earth's atmosphere are nitrogen and oxygen. Nitrogen makes up about 78-79% of Earth's atmosphere, and oxygen is only about 20.9 or 21% of Earth's atmosphere. So that means that most of the gas in the Earth's atmosphere is nitrogen, and we don't use that. So we don't really take too much into consideration the nitrogen gas that's in the Earth's atmosphere. But of course, we're concerned about the oxygen gas, right? Because that's what we're using in our metabolism. So Dalton's law helps to explain why it is more difficult to breathe as one goes higher in altitude. So the composition of gas as we go higher in altitude doesn't change. The Earth's atmosphere is still roughly 20.9 or 21% oxygen even at high altitude, but there is less total atmospheric pressure that's driving that oxygen to diffuse from the air in the alveoli into the bloodstream. And so the higher that partial pressure of what we call the partial pressure of oxygen is, the easier it's going to be for that oxygen to diffuse into the bloodstream. The lower the partial pressure of oxygen that's in the air in the alveoli, the harder it's going to be for that oxygen to diffuse from the air in the alveoli into the bloodstream. So as I kind of explained there in my summary of this, the Earth's atmosphere still contains 20.9% oxygen even at high altitudes. It's just that there is less pressure driving that oxygen to diffuse into the bloodstream. Right? There's a couple of examples of this in some of the practice questions that I have for you in Moodle in the lab reports, and there's also a table that you'll need to use. There's a table that shows the atmospheric pressure at different altitudes. You don't have to memorize those. I'm simply looking for you to be able to take the atmospheric pressure at a certain altitude and use that atmospheric pressure to calculate the partial pressure of oxygen at that altitude. So we'll go through an example calculation here for that. So if I were to say calculate the partial pressure of oxygen if the total atmospheric pressure is 688 millimeters of mercury. So remember that this is a pressure, and our units for pressure are millimeters of mercury. So it's a pretty simple equation, or simply pretty simple calculation, in that we take the total atmospheric pressure, which is 688 millimeters of mercury, and we multiply that by 0.209, which is the decimal form of 20.9%. You could also multiply it by 0.21, or 0.21, which is the decimal form of 21%. And you should get somewhere with this example here, you should get somewhere around 143.8 millimeters of mercury for the partial pressure of oxygen. So I say PO2 there because the term PO2 means partial pressure of oxygen. So hopefully that kind of helps to clarify things, and I think there's enough practice questions in Moodle that I feel like you all should probably have a pretty good grasp of that. And it's just one of those things that you just have to kind of get into doing a couple of calculations, just work with the numbers, and I think it'll make sense that way. But if you have any questions, of course, feel free to reach out to me. I'm happy to maybe give you some more practice questions, or just follow up with you and see where we need to clarify any confusion. So the last part of this we'll examine are a couple of formulas: alveolar ventilation rate, minute ventilation rate, and effective ventilation. The only one that I'm really going to ask you to calculate in a question is the alveolar ventilation rate, or AVR, which is the ventilation rate. So ventilation is going to be milliliters of that particular gas in a specific amount of time. So the units here are going to be in milliliters per minute. So the alveolar ventilation rate takes into account how fast you're breathing, so it takes into account your breathing rate, your breaths per minute, and it multiplies that by the tidal volume minus the dead space. Now the tidal volume is just whatever volume of air you happen to be breathing at that particular point during your inhalation and exhalation cycles, and it subtracts what we call the anatomical dead space. And the anatomical dead space it takes into account the fact that all of the air, a lot of the air that's going into the respiratory system is not making it to the alveoli. So recall that air has to get to the alveoli in order for gas exchange to take place, because that's where the capillaries are that are picking up that oxygen. And so during our normal inhalation cycle, when we're inhaling air, a lot of that does go to the alveoli, but a lot of that just stays in the bronchi, the bronchioles, in the trachea and things like that. And that's what we call anatomical dead space, because there's air in those spaces, in those places, but there's no gas exchange taking place. So that air is just kind of useless sitting in those places. So alveolar ventilation rate takes into account the fact that not all of the air that's moving into and out of the respiratory system is actually getting to and from the alveoli, where gas exchange takes place. So the alveolar ventilation rate is simply examining how much air per minute is actually getting to the gas exchange places, the respiratory membrane in the alveoli. So that's the kind of one major formula that I will have you complete a calculation on in the quiz. The other is minute ventilation and effective ventilation. I want you to be familiar with for the purposes of the exams, but I'm not going to have you commit them to memory for the purposes of calculating numbers during a quiz. Minute ventilation rate, which again, just like alveolar ventilation rate, is in milliliters per minute, and it simply takes into account the number of breaths that are occurring per minute and multiplying that by the current tidal volume. So that rate, minute ventilation rate, simply estimates how much air is moving into and out of the respiratory system. But notice that it doesn't take into account dead space like the alveolar ventilation rate. So notice that minute ventilation rate is a kind of much more simplified view of just how much volume per minute is getting into and out of the entire respiratory system. And then finally, that brings us to effective ventilation rate, which takes the effective ventilation, not effective ventilation rate. Effective ventilation is actually a percentage because it divides the alveolar ventilation rate by the minute ventilation rate. And when you divide two numbers that are the same units, they become dimensionless and they become a percentage, right? So effective ventilation is a percentage. And effective ventilation is simply the percentage of air that's actually getting to the alveoli, right? So it takes the alveolar ventilation rate and looks at it as a percentage of the minute ventilation rate. So of all of that air that got into the respiratory system, how much percentage or what percentage of it actually got to the alveoli where gas exchange is taking place. And we see that different breathing rates as well as depths will significantly affect the percent effective ventilation, in that the percent effective ventilation is much higher when we are undergoing slow, deep breathing. Because that means that with each of those slow, deep breaths, there's a much higher percentage of that air that's actually getting to the alveoli where gas exchange is taking place. On the other hand, rapid, shallow breathing decreases the percent effective ventilation, because it means that, yes, you're moving a pretty good amount of air very rapidly in and out of the respiratory system, but not much of it is actually getting to the alveoli where it's needed to exchange oxygen and carbon dioxide. So percent effective ventilation, I just want you to kind of keep in mind that if that percentage increases, that means that more of the air that we're taking in per minute is actually getting to the alveoli, and if that percentage decreases, there's less air, kind of smaller volumes or smaller percentage of that is actually getting to the alveoli where gas exchange is taking place. And effective ventilation percentages can be increased by slow, deep breathing and can be decreased by rapid, shallow breathing. So that really kind of summarizes it for the major topics, major concepts in the physiology of the respiratory system. Please feel free to reach out to me at any time if you have any questions or if there's any confusion. I'm happy to work with you through any of these to help clarify that.